Ma'am, we are live.
Okay. Good evening, all. Welcome to the lecture number 481, Refractive Surgery, lecture number 32. Today's topic for today is phakic intraocular lens, that is complication management, to be presented by Dr. Prafulla Maharana, sir. Introducing our chairperson for today, Dr. Gaurav Luthra, sir. Sir is MSFWCRS, FACO. He's the director and head of Drishti Eye Institute, Dehradun. His special interest lies in refractive surgery, challenging adult and pediatric cataract surgery and keratoconus. He is also the chairman of academics and past president of Intraocular Implant and Refractive Society of India. He is the founder, member, and honorary fellow of World College of Refractive Surgery. Sir has been awarded honorary fellowship FACO in refractive surgery by All India College of Ophthalmology. He has done over 200 live surgery demonstrations and has 5 orations and 4 named national awards. We welcome you, sir. Coming to moderator for today, it's Dr. Tusha Om Prakash, sir. He's the Chief Executive Officer at Dr. Om Prakash Group of Eye Hospitals, Punjab. His field of interest lie in cataract and refractive surgery, keratoconus, and dry eye disease. Sir has received Best Video Award in Cataract Surgery in IIRSI Delhi 2023 and DOS 2024. He has been awarded Gold Medal for exemplary work in ophthalmology by Bombay Ophthalmological Association. Sir has also received the Best Paper of Session in APA CRS 2019, Kyoto, Japan. He is the recipient of various prizes for video presentations in many conferences around the world. Sir has organized and led instructional courses at international conferences, including AAO, ASCRS, and ESCRS. He has performed live surgical demonstrations of cataract and smile at various national conferences. Sir has also contributed chapters to various ophthalmology textbooks and have more than 12 publications. He is inducted as a reviewer for the International Journal of Clinical Ophthalmology. We welcome you, sir.
Thank you.
Coming to the speaker of today, Dr. Prafulla Maharana, sir. Sir is MD and has done his senior residency in cornea, cataract, and refractive from RPC AIIMS, New Delhi. He is the additional professor of RP Center, AIIMS, New Delhi. He is the secretary of DOS. Sir is the chief editor of Ophthalmology Clinics 2, and postgraduate ophthalmology book series. He has published around 395 Google Scholar articles, 156 PubMed Index papers, and 50 chapters in national and international books. He's also received the Best Surgical Technique Award from Rensco, Young Achiever Award at ISCKRS. He has received the Ajit Babu Maji Award and awards for Best Paper in various conferences. So he's also the premier principal investigator in 2 ICMR trials and co-principal investigator in 18 trials, including 2 multicentric and international. He's also the teaching co-in charge of RP Center since 2016. We welcome you, sir.
Thank
So
you.
kindly share your screen.
Thank you and good evening, Gaurav sir and Tushya.
I'm sorry, I joined a little late.
No, we are waiting for you, sir. There will be some background noise, and I'm sorry for that because it's a holiday and my kid is watching cartoons, so I can't stop him right now. So I hope the noise is not that much. So today's topic is Phakic IOL complications and its management. And for postgraduate, it's
Oh.
not a very important topic, I would say. Why? Because in exam, most likely you are going to get a short note on this, or maybe few viva questions if you get a case of say post ICL RD or corneal decompensation. So I'll keep it brief so that only thing that matters for postgraduate exam. Broadly, this intraocular complication and post-op complication, you can categorize this. And these are the major complications. There are some rare complication also, which I'll enumerate later subsequently. Intraoperatively, most common is the inverted opening of ICL that I have seen my fellows and resident, they struggle with that. Chipping of ICL is one problem if you don't load it properly, or you are injecting a little bit in a hurry, applying too much pressure. But chipping of ICL that doesn't cause that much problem. Post operatively, I think there are 3 main problems. One is cataract, the second is glaucoma, and some rare complications like endothelial problem or chronic uveitis or even TAS. So those are the problem. Immediate post-op complications include your rotations, specifically if you are putting a toric IL, then the IOL may rotate. That is one problem with this, and then vault related issues. So we'll touch upon all these things in individual slides. So I'll come to the cataract, the most probably the problem that has been discussed a lot. However, as you can see, a latest study that by Shoei et al., where they check for 10-year outcome, they found that the incidence is 12.1% only. And in one of the series, the incidence was almost, I would say, I think some text is not coming out here. So in one of the series by Sanchez et al., what they found that out of the 190 eyes, almost 2.1% of the patients, they develop cataract, which was nuclear sclerosis. And posterior subcapsular was seen in only 1.2% of the cases, which was significant, and the patient needed phacoemulsification. So what I mean to say is cataract after phakic IOL is rare. Even if it occurs, most of the cases it is not clinically significant or doesn't warrant surgery. Now, broadly, the causes you can divide into two types. All the early cataract that are primarily due to trauma during surgery. Late cataract is usually because of your low vault. There is the gap between your entry lens capsule and ICL is very less. That hampers the nutrition of the lens and metabolic exchange between aqueous and the lens, and that leads to cataractogenesis. So that is the cause of late cataract. And just to if you see this statement, most common type of isolated cataract is intersubcapsular cataract only, and the incidence range between 0.3 to 28%. This is from a review article which I'll show you in the end. It's an excellent review article in IGO where they have evaluated all the papers on ICL complication, and average onset, if you see, it's almost 3.4 to 1. Median or age is 3.4 years. So it's not that immediately patient will have cataract. Usually the cataract develops 3 to 4 years later. But when I say this, it's a rare complication. At times they can be very I'm not moving. At times, the complications may be severe also. As per the FDA trial, the examiner very fond of asking you what was the rate in FDA trial for VGN ICL. As you can see here, the incidence of nuclear cataract was 1%, and the incidence of intersubcapsular cataract was 0.4%. And this was after 2 years of follow-up in that ophthalmology study published by FDA. So this is the rate as per FDA. Now I'll show you a video. Although the cataract incidence is rare, and this is one of the very severe what to say phakic IOL complication that was referred to me from Lucknow by one of my fellow. And as you can see, this patient, the patient was a 19-year-old. So even doing ICL as per FDA guideline was not recommended, but somehow the patient went ahead with the surgery. And you can see this is the right eye of the patient, right? The patient developed TAS, and the left eye he developed cataract. And this is the cataract surgery that I did. Most of the time, as I said, it's PSC or nuclear cataract. However, here you can see it was a intumescent cataract, and you see the vault. The vault is good enough, but there is intumescent cataract. This suggests there was trauma during surgery. So, as I said, early cataract is usually due to trauma. But if you notice here, for what I'm trying to remove the IPCL. But normally these cases, no, it's very easy, but here the IOL was not moving at all to begin with. And when I tried little bit, you can see a lot of pigments were there on the IOL itself, and there was foam adhesion between the iris and the lens. So this suggests when you are injecting the IPCL or ICL or any form of phakic IOL, you will have to be careful. Your goal is not just to push it between the lens and iris somehow or anyhow, but the goal should be to not damage the surrounding structures like iris or angle. I have seen a few of my fellow, their goal is just to tuck in the IOL by whatever means, but that shouldn't be the goal. You have to be very careful. So removing the IPCL or ICL is not that difficult. In that case, there was dense inflammation post-operatively, so that's why it was difficult. And the patient was to my so this was the intumescent cataract. No, rest of the steps are similar to how we do intumescent cataract surgery. This is a microneedle assisted aspiration. However, it was so intumescent that in spite of that, the capsule extended. So in these cases, you treat it like a intumescent cataract. I'll just fast forward it. So stay in the capsule, do a rexis, try to do a low and slow phacoemulsification, and try not to aspirate the cortical matter from this extended rexus area. You should approach this area in the end. And if you manage properly, phacoemulsification is possible in such cases. And once you are done, you can achieve a central 5 to 6 rexus by using your intravitreal seizures, rexus, and forceps. And once you achieve that, once you are sure that there is no posterior extension, you can put a IOL in the bag. So in this patient, this was the IQ lens I put in this patient. So the patient was doing fine with the left eye. And the right eye, as I had shown you the picture in the beginning, it was a task with complete corneal edema, limbus to limbus, and with extensive posterior. And again, that case, what I did the PK with a SFI. So both the eyes are doing fine. However, remember, even if it's said that cataract is rare, but that doesn't mean if you don't pay good attention while performing the surgery, it cannot occur. At times, it can become very serious also. So this was the case that I think luckily the patient is having good vision. In right eye is having 6 to 8 and left eye 6 6. So cataract can be dangerous at times if you don't follow the routine protocol. The second major problem is endothelial cell count. I'm primarily a corneal surgeon, and just to highlight you how rare is it. So far, we have operated only one patient of post ICL corneal edema, persistent corneal edema with dissect. Most of the cases were with the previous version of phakic IOL, like artisan IOL. So with current IOLs, phakic IOLs, the chances of endothelial damage is very less unless your case selection is not proper. There is a proper FDA guideline. There is a minimum ACD, there is a minimum endothelial count beyond which you should avoid surgery. But if you don't follow that, then you may land up in corneal decompensation. The other aspect you must remember is these patients are young, they are in their 20s. So they are going to live for another 40, 60 years. And you have to remember the normal rate of endothelial cell loss, which is almost 14 cells per square per year. So if you remember that, and you remember the age and the patient's baseline endothelial count, then it helps, because the patient is going to live a long life, and immediately there may not be problem, but 10 year 15 year down the line, you never know what's going to happen. So you have to be careful. And there is a hypothesis why this endothelial cell count loss happens over a uh, period of say a long period. The study, although it's very old study, what they found that in spite of doing all these measures, some sort of chronic low grade inflammation can go on in Phakic IOL patients. So it's better to be on safer side and follow the FDA guideline for case selection. And this is the study where they explored the rate of endothelial cell loss with the latest or ICL, because nowadays ICL is the most commonly performed procedure. So you can quote this figure, like the range is between 0.4 to 22%. Why the 22% is because if you go through this study, you will find on all these patients there was some and struggle during surgery, and the surgeon's expertise was not that much. So surgeon's expertise do matter, and you have to carefully choose your viscoelastic when doing your surgery. So third major problem is glaucoma or post-op IOP rise, and as I have enumerated here, these are the major causes: pupillary block, uveitic, pigment dispersal, steroid induced, viscoelastic residual if you don't remove the viscoelastic properly. And that's why nowadays a lot of people, they have set up to hydro assisted implantation rather than visco assisted implantation. Aqueous misdirection, although rare, but that can occur. Narrow entry chamber angle, that can also be a cause for your post-op IOP spike. Uveitis pupillary block, it's very rare nowadays, pupillary block, because of the central horn in ICL. And pigment dispersion, yes, again you have to choose the diameter, the length of ICL properly. If there is chronic friction between your between your IPCL or ICL and the posterior surface of iris, that will release pigment, and that can produce glaucoma in long run. But remember, most of the IOP spikes following ICL or phakic IOL is steroid induced. This 64% is this 64% of the 4.4%. The reported incidence of glaucoma following phakic IOL is almost 4.4%, and 64% out of that is steroid induced. Earlier, a lot of surgeon used to blame the IOL, but actually it is the steroid that causes. And always remember, patients with family history of open angle glaucoma and myopic patient, they are already at risk of steroid induced glaucoma. And most of this ICL is done in myopic patients. So by default, you are giving steroid to a patient who is already prone to steroid induced glaucoma. So you'll have to be careful and monitor the IOP carefully in such patients. Viscoelastic residue, nowadays, I don't think it's a major problem unless you are a very careless surgeon. Nowadays, I have seen most of the surgeons, they ensure complete viscoelastic removal. Aqueous misdirection, yes, especially if your ICL or phakic IOL is undersized. If it is undersized, it keeps on pricking or zonules and it keeps on blocking your angles intermittently. So the aqueous direction, which was supposed to go from posterior chamber to anterior chamber, because of this repeated or intermittent ICL blockade, it goes through the journal to the posterior cavity, and that causes aqueous misdirection syndrome. Although rare, I think there are one or two case reports about this, and you should be well aware of this. Narrow anterior chamber angle. Yeah, this is a study, even experimental study. Also, they have found that once you put the IPCL or ICL in sulcus, for next till 1 month, the anterior chamber angle is little bit shallow. The exact cause is not known, but however, it may be mechanical factor that plays the role. But there is definitely narrowing of the anterior chamber angle in these patients. But most of these cases are they never develop glaucoma. So how to treat such cases? Most of the cases respond by stopping the steroid and starting anti-glaucoma medication. Surgery, and again, as at RP Center, we have a in my unit there is a glaucoma subspecialty also, and over last 3 years we have seen two patients of post IPCL intractable glaucoma where they had to go for a trap, and the major cause was pigment dispersion, not the immediate surgical trauma. However, chronic pigment dispersion followed by glaucoma, that was the reason for which they had to go for trap. So surgery is rarely required, but yes, it may be it is an option if the glaucoma is intractable. Post op uveitis, again, it's not that common nowadays. Earlier, it used to be very common. And if you see this notice, this study by Perez et al., it was a 96 study where they found that some sort of low grade interchamber inflammation may persist up to 2 years. Nowadays, and if your sizing is proper and the patient doesn't have tendency for post op inflammation, you remember the first video that I showed, the patient developed right eye TAS and left eye. Traumatic cataract or iatrogenic cataract. The right eye task, the patient had history of chronic uveitis. That's why it's very important. You have to choose your patient carefully. In that patient, the patient was treated for vitritis almost 6 months back. Then the vitritis got controlled, and then the IPCL was planned. And after that, after the IPCL, he had severe inflammation. So you have to choose your cases carefully. Urus javalia, persistent dilatation people can be there. There are two, three reports post IPCL. The sorry, the mechanism that has been proposed is if you leave viscoelastic, they may lead to uh, some closure of your iris root, and that can lead to some ischemia and iris muscle atrophy. That may manifest as Ehlers-Danlos syndrome. Iris and ciliaris is rare; it's coincidental. And IP and Phakic IOL cannot be directly implicated as a causative agent for that. Then all these retinal problems like CNVM, lacunar cracks, remember they are complication of myopia per se. Any patient of high myopic, they have a tendency for this complication. But there is a hypothesis that once you put an IPCL in a young patient, myopic patient, there may be some biomechanical alteration that may further hasten or precipitate this process. However, it is not proven yet. Then retinal hiatus in RD, again, as I said, most of these complications are by default the natural complications of pathological myopia. However, if you discuss with the retinal surgeon, they have a different point of view. Few of the surgeons they say when you are doing surgery, any surgery in myopic patient, the chances of getting a PVD if it has not been it hasn't occurred yet is very high. So because of this PVD, there may be some problem associated with the ICL surgery. And again, if my experience suggests till now, I think I have seen two ICL patient developing RD for which retinal detachment surgery was done. But both the patients, the refractive power is almost around -16, -18. Endophthalmitis, it is very rare. As you can see, the incidence is 0.0167%. and most of these cases are aseptic or TAS, and as I shown you in that picture. However, any intraocular procedure, remember, carries a risk of endophthalmitis. I have seen one patient developing bilateral endophthalmitis during COVID time, following bilateral implantation of the ICL by same surgeon on same day. So that probability is still there. However, if you follow all the proper precautions, it's very unlikely. Night vision symptom, yes, few of the patient they complain in almost in a study, in fact in a study they found that 47% of the patients they have these symptoms of non-specific glare and halo or starburst. All these are again a mismatch between your pupillary diameter, mesopic pupillary diameter, your white diameter, and the ICL optical diameter. So proper planning, pre-op planning is absolutely essential. And high curvature ICL, and rarely earlier people used to do PI, and rarely PI has also been implicated as a cause of this glare and halos. However, these are rare, and it has been noted that by within 2 months, most of the patient they adapt to the symptoms. Now, abnormal position of ICL, this is one of the problem, especially if you are a beginner and you don't know the exact technique. However, if you ask me the significant complication that I have come across, this is probably the very common complications, especially during the early part of learning curve for IPCL or ICL surgery. Dislocation is rare unless there is trauma or the sizing is problematic and your pupil is not stable. ICL rotation, especially for toric IPCL, any rotation less than 5 degree doesn't affect that much to the final visual acuity. However, if it is more than 10, you have to take the patient to OR and rotate it. ICL inversion, as I have highlighted, this could be the factor. It occurs in almost 1.8% of the cases. Factor like lens installation, surgical incision, and entry chamber depth may play a role, but most of the time, the major problem is injection process. I'll show you. I'll be showing you three videos because this is probably the most common complication when I ask few of my fellows and key if you have any complication of ICL, and this is the most common complication, and they send me these videos. So if you notice here, this was a toric IPCL plan, and you just observe here the problem is most of the time the injection process. If you notice here, you always remember the company gives you a hole. This should always be on right side. So as you can see, and while injecting, it's going into right side. Everything was going fine. This was going to the right of the surgeon, and this was fine then. And I've seen few of the surgeon, no, they don't open the ICL into eye completely. They leave a part into the wound so that they can adjust. And this is what was done in this patient. As you can see here, see this haptic was deliberately kept out so that it can be adjusted. Till this point, it is fine. But if you notice the push, right? The surgeon then pushes it, and because of this push, it became an inverted ICL. So this is the process. This is a problem of your insertion. The IPCL was opening fine. The injector was performing fine. Only, only problem was the push by the surgeon. I'll show you another video, and this is Katsi daughter Pranita Sai. See this patient, right? So here, if you notice here, a lot of things are not right. First of all, the patient is very uncooperative. You can see the pupil was not fully dilated, right? And it was a struggle from the beginning only. So if you are struggling with all this thing, there is no harm in blocking the patient, because a simple peribulbar or even use of intracameral anesthesia can make your life quite easy. You can see here the pupil are so floppy. In spite of injecting, the pupil was not allowing the IOL to open properly. So as I showed you in the causes, rarely the iris may be the culprit. So this here you can see the iris didn't allow the IOL to go in the perfect plane, and the the ICL become inverted. So what to do if such things happen? This is a complete video. What is to be done? See, loading was fine, right? So loading was perfect. The probably problem was injection process. Again, the patient was being done under topical anesthesia, and see the pupil size. It's again not that much well dilated. For an expert, this is ideal, remember, because if too much dilatation can also lead to a problem. But if you are a beginner and just started the surgeries, it's better to have a properly dilated pupil. And you can see here, right, the IOL insertion, when the injection, the IOL was inserted, the eyeball was pushed towards nasally, and the IOL was not in the surgeon's view. This is the problem. When you're injecting the IPCL or ICL, remember, always keep on watching the right side, that hole. That is the landmark for you to check whether you are injecting in right direction or not. Removing the ICL is not an easy, is a very easy task, sorry. And most of the time, once you remove it, it's always a good idea to put it back to the bottle, because ICL or IPCL, you have to keep them wet. You cannot dry them. If you dry them, then again the loading and insertion becomes difficult. So the ICL was removed and subsequently it was injected. Now this time you see the surgeon is watching where the ICL is going, right? In the previous attempt, it was a blind procedure, like it was just injected like that. But here, the surgeon was constantly monitoring where is it going. So this is important, when you are injecting because at times it's a wound assisted insertion, and the eyeball may drift. So what you can do is you can use the help of your second instrument also to stabilize the glow. So with this, I think these are the major complication, and often an examiner often tend to ask you this question: what is the difference between the ICL with hole and no hole? If you see here, right, all the complication with no hole ICL were maximum, except this night vision problem. Night vision problem is more with old ICL. So this was the review article. You can go through. It's a IGO article. It's freely accessible. You can download it and go through it, and it has all this complication enumerated nicely with literature. And for a postgraduate student, you have to quote some things. When you quote that, okay, the endothelial loss is 5.5%, the examiner will ask you what is your reference from where you are quoting this. You can quote this article, or maybe the Krasmer chapter. So with this, I'll conclude here, and I would like to invite you all to our annual DOS conference, which we are going to do on between 13 to 15 June at Bharat Mandapam, the venue where the G20 summit was done. And with this, I'll conclude here. Thank you so much.
That was a great presentation, Dr. Prafulla. So you had enumerated all the
Thank you, sir. But
complications.
I will just say one thing. It was a struggle to get complications of ICL videos
Yeah,
and clips. That suggests is a very rare one. So
but
it's
you had
very
covered
rare.
like most of the
Thank you. Very
complications very
comprehensive talk.
beautifully. I think it was a very good demonstration for all the postgraduates, because for them, for a 5 or 10 marker, it was a precise information that they needed. So, Dr. Gaurav, any take on like, just wanted to ask you, what is your preference? Do you do ICLs, bilateral implantation on the same day, or unilateral? Seeing at
No.
the so many complications that,
So you don't really see that many complications. The only
yeah,
thing is
please.
that when you do see, you may get a vault surprise. So that's the one thing which you're always worried about. That you're aiming for a vault of say 500 or something, 5 to 600, and you may not get that vault every time because that remains a little bit of a gray area even after so many years of using ICLs. So I personally feel that after the first eye, I would like to see next day. I typically do them on one day after the other. So if I'm done one eye today, I will then next morning see the vault and everything, and then I'll go ahead with the same with the second eye surgery. And if I feel that the vault was a little too low or too high for my comfort, I might switch. See, I also have the comfort of doing the intraoperative OCT, so technically I could actually see the vault and then do the second eye, but I still kind of don't do this, and I still prefer to do it on different days. Bilateral implants, some people are doing regularly, and I
What
think they're
about,
doing a great job. But as Dr. Prafulla said, even if one patient gets a bilateral end off, then you're gone.
Bilateral, what I have seen,
I
especially
think,
at RP Center, no, Dr. Khoker does in maximum ICLs. So what he does one eye in the morning at 8 a.m. and then at 12 p.m. he will have a look in the patient on slit lamp. Then he
yeah,
will operate the other eye in a different OT, not the same OT, in a different table with completely different set of instrument. But again, as I said, I do it on 2 subsequent days, no matter how much you try. But if you land up in one complication, then leave the patient. The surgeon will go into depression because these are eyes with 6/6 corrected, best corrected vision 6/6 where we are operating. So I think it's better. It's
So I
if
think
there is no
that should
compulsion,
be an
better to
IT.
go on 2 different days.
Yeah, so that's great. Like that is the ideal situation that we do it and then we wait for at least 5 7 days. Why? Because I do it under visco, so I'm not doing under hydro. So at times the vault it changes in few days also. So we usually give it like 3 4 5 6 days, and if the vault is within the ideal range, we do it quickly, or if it is slightly less or above, then we usually wait for 5 7 days and then we order another phakic IOL so that we can have a chance of changing the size for the next eye. So I think that's the what do you say? Like I think we should all do this only because we have outliers definitely in ICL measurement because and there is a lot of AI technologies which are coming in, but still now the outliers, we usually get 5% outliers currently with the ICLs right now. So what,
Also, I think, the
anything
point
you
that you
want?
raised, Dr. Prafulla, I'm sorry. I was just
Yeah,
mentioning that
yes, sir.
the point you raised about the uveitis part, like anybody who has had previous instances of vitritis or uveitis, I would never implant a phakic lens because I have burnt my fingers. My patient, although my patient never had a history of uveitis, but during COVID times, this young lady who had been post ICL for 2 years came in with sudden post vaccination. She came in with bilateral uveitis, probably either because of COVID or COVID vaccine or something, and she went on to develop very severe hypopyon and severe inflammation, and we managed to control it with pupillary blocks and all. I did PIs, laser PIs and all, settled it. She came back again after 3 4 months with just the similar intumescent cataract as in your patient. So I think that pigment which was there is basically even in the fellow eye, the one eye you had probably got TAS, the fellow eye also must be having low grade uveitis, and that is why the ICL was carrying a lot of pigment. And my patient had bilateral uveitis, had bilateral very similar intumescent cataracts, even though the vault was fine. And we also went into, in spite of whatever I did, the moment I touched the capsule with my 26 gauge to decompress it, it went into a Argentinian flag sign. So these intumescent cataracts are bad. So I think any eye which is prone to inflammation should be a total no-no for a phakic lens. I think this was a very important message that you sent out today.
Yes, please. So true that that was a very good point raised by Dr. Prafulla. So, Dr. Prafulla, just wanted to ask you, like, how in your career, how many phakic IOL exchanges have you done? Like,
Now, I haven't done many, but yes, I have two uh, lenses where my fellow put it in a wrong direction, and I had to do
okay,
it intraoperatively, take it out and inject it back. But we haven't
and
done even I haven't seen anyone.
what?
I think probably Dr. Rajesh, I've seen when because we all were in the same unit. Dr. Rajesh had to explant one IPCL because again the same issue. The inflammation was not settling down in spite of steroid, PST, everything we tried. Vault was fine, everything was fine, but there was inflammation, and we the exact cause we still don't know. But that the moment the IPCL was explanted, the eye went fine. I don't know what was the correlation,
uh,
but there was something
Did you
wrong
do
with that
it
system.
through UBM in that case?
Yes,
Like, did you
UBM,
get
we
to
have
do
microscope
UBM?
IO, we have microscope into OCT, UBM, everything. Everything
Everything
was
was
attempted, but that inflammation was not going. Even the patient was atropinized, thinking that maybe some cyclitis is going on, but nothing worked in that patient. Maybe some sort of
What about you, Dr.
I'm sorry, what's the question?
So,
uveitis part, sir.
so have you ever done phakic IOL exchanges in your practice? And what are the reasons
Okay,
for that?
so I have, of course, done a few Phakic IOL exchanges. One patient was having a low vault, very low vault of just about 50 to 100 microns. And we went with an ICL exchange, and intraoperatively, we ordered a bigger size. But funnily enough, when I implanted the next size, the vault was still just about 50 microns. So then, and we could luckily, because of intraoperative OCT, we could appreciate that the vault was low. So we explanted it right then. That was one instance. In other instances where we had a very high vault, we were getting just about 1.2 millimeters, and the chamber depth was not great. So it was just about 3 millimeters. So 1.2 millimeters was causing potential, like patient had to be maintained on IOTIM plus because we were worried about angle closure. So then we ordered a smaller size, and then we did the ICL exchange and we were fine. Similarly, I remember one hyperopic ICL where I had to do an exchange because again the vault was very high and they don't have a central hole also. So although we had PIs in place, but it was a shallow, but the eye was luckily had a 3 millimeter AC depth. That's why we'd gone with a hyperopic ICL. So we did the exchange and patient did extremely well after that. So bilateral patient, we had done about a +9 or something. That's about 3 years back. And so a few of our hyperopes have also been very good actually. So I have a few instances of ICL exchange, but mostly because of vault rather than anything else. So either a very low vault where there is a, kind of early signs of very, anti-subcapsular cataract creeping in, or a very high vault which is not being tolerated is the only times when I've had to do an ICL exchange.
And so, what is your cutoff for the low vault and the high vault? Like where you think of these things
So
like
I don't have a cutoff, Tushar, because if a low vault is say even 100 microns and it's being tolerated well and I'm not seeing any cataract formation, I'll usually keep the patient on follow-up. And
okay.
usually you'll start seeing that funny kind of anterior subcapsular, very early changes happening, and then that's the warning sign that something is not right. So then you have to immediately act upon it. But there are other patients of mine where I've had a vault of 100 microns for the last 5, 6 years, and there is no cataract formation, and they are continuing to do extremely well. But if you have a toric ICL, especially of a very high powered astigmatism with a very low vault, you will get sometimes ICL rotation. Now that can be a problem, and then you have to, and sometimes, if there's an ICL rotation, you can kind of reposition it once, but suppose it rotates again, then you'll have to go for an exchange. So a very low vault may require an exchange because if it's a high powered toric ICL. And upper limit, I have one or two patients now who are like 1 mm, like 1,000 microns plus, even 1,100 to 1,200 microns. But if their AC depth was like 3.5 and the angles are still open, then I don't have to do anything. And I know that over time, the vaults will come down. So over a few years, you'll notice that, they start coming down below 1,000 microns. And then the eye is tolerating them well. So if the eye is tolerating it well, I will not go in and, do an ICL exchange unnecessarily. And let's ask Dr. Prafulla what his threshold is for the vault low and the high, and if he has any thoughts on that.
Vault, as you said, anything below 150, uh, we have at our center basically, we have a protocol sort of thing. So all of us follow that. So anything below 150, you have to try something like rotating it or trying some few small things. If that doesn't work, it's better to exchange. But as sir said, we have such patients, no matter what size ICL you put, the vault was coming less than almost 120 or 100, maybe some biomechanical, or maybe the orbital anatomy was like that. So no matter what IOL you put, the vault is going to be that less. And highest vault I have seen 1200, and that patient is still doing fine. We haven't, because the patient refused, because he was so happy with his outcome, and it was for some professional reason, so he didn't want any intervention. कि माइट मेरा तो job लग गया, I'll see later on जो भी होगा. So
I
that
know
was
sometimes you
it.
want to do something and the patient doesn't want it. That's very funny. And those patient that you're talking, Dr. Prafulla, where whatever you might do and you might put a higher size, the vault remains very low. That's usually because of zonal laxity. So if there is zonal laxity, I've had one patient like that where, we did this and in spite of whatever we did, the vault would remain very low. Then we realized that the patient had lax zonules. And then, I mean, there's little we could do, but the patient didn't want it explanted, as you're saying. So he's now under follow-up. It's been 3, 4 years. He's maintaining good vision and there is no cataract formation yet. So we have allowed him to be.
So even one patient, funny I lost him because the moment I said your vault is less, I'm going to do something. He never came back to me with the fear that no, I'm seeing 6/6. I don't want to get any
They are very
intervention.
happy with their vision usually. That's the
Yes.
that's the very gratifying kind of a surgery, no doubt.
So I think like as I think Dr. Prafulla and Dr. Gaurav, you both have intraoperative OCT. We also luckily have that. So that gives you a very good advantage of like rotating it. If there's a high vault, you can just rotate it 90 degree and reduce the vault. So that is one advantage that the intraoperative OCT users have. So
Yes,
I
true.
think,
For
yeah,
a few cases, for example, for me, I think for DMEC and second for phakic IOL surgery, it's a boon. If you have, it definitely helps you in a lot of things.
Absolutely.
so Dr.
I
Prafulla,
think
you
there's
also
one more
do,
thing which I thought, sorry, yes, Sushil.
sorry, please go ahead, sir, please.
I was just talking about one situation which I've encountered 2, 3 times in my career, where the ICL gets stuck in the incision. So I thought, that's important for the postgraduates to understand. See, what happens is that if you're attempting if nozzle of the cartridge is inside the, I mean, the internal lip of the wound with the like slightly smaller incisions than 2.5 or something, and is not, through.
So your voice is
Am I
breaking.
moves, or if suddenly you're not,
Sorry,
yeah.
your voice is
Sometimes,
breaking. So you can repeat again.
yeah. So sometimes, now can you hear me?
Yes, sir.
Okay, so sometimes, while injecting, if you're not using proper counter traction, I mean counter pressure with your manipulator or something, the ICL may be half injected and it may just kind of, get stuck inside the incision. Then it becomes very challenging because you don't know whether to pull it or to push it. So typically the answer to that is that using the ICL holding forceps, if you just hold it from one of the ears or from the area between the ears, it's best to pull it out. Because sometimes I've seen some beginner surgeons and fellows, they have most of the ICL is inside, they keep trying to push it inside, and you might damage the ICL also in this situation. So that's another thing that I think is worth mentioning.
That's a very good point. Like even Dr. Prafulla also mentioned using the second-hand instrument to provide counter traction. So
Yes.
that makes it very easy because they're all at times you get these uncooperative eyes who are not fixating. So that plays a
If
very
you
good
notice, if you remember that video, no, that was in fact, that was a 2.78 incision, I guess. Company recommends 3.2. The wound
yeah.
assisted incision was attempted, and the problem
Mm.
was with the last push by the surgeon, not by the
I
ICL.
know
The
it was
push,
quite amazing
yeah.
because yes, I
Even the
agree.
second-hand instrument, like if you're using that, so I use a blunt one. So if there's any flipping or any thing happening in the interior chamber with the second-hand instrument, I just slightly tuck it and I make sure that it is not getting inverted. So that's another advantage. Like you can do it right there and then. So that use of second-hand instrument is very important, I feel.
Also, I think what Dr. Prafulla mentioned about the inverted ICL instance being about 1 to 2%, I think that's again very important. It's very important for people who are beginner surgeons to understand that there is that possibility and they will not realize it. So either you have an intraoperative OCT, or you are second option, of course, is the most important, that you monitor the holes on the haptics and make sure that you are watching them. As you are injecting, you have to make sure that you are seeing that they are opening up in the correct way. But even more important, I think, is post-operatively on the post-op day to look for the ICL vault. Because, I remember one patient being referred to me where the ICL had been inverted. The surgeon did not realize ICL had been in the eye for a good 15 days and there was already a cataract formation. There was little you could do. So inverted ICL is a disaster. It's an emergency and should be tackled immediately if that happens, either on table itself, or if not, then the next day for sure. So
Great, sir. I think we've covered everything. Like anything else you want to add, Dr. Praful or Dr.
Just
Gaurav,
want
sir?
to discuss one thing. We have seen what we have seen in a lot of patients. We can see fine bubbles in the capsule, interlens capsule, immediately after injecting the IOL, even in post-op day 1 or 2, especially in one of my SR, now he's in Gujarat. His case, no, the bubbles were quite apparent, but it didn't cause any problem, and I think that persisted for almost 1 month. Then it disappeared. Any experience of that, sir?
yes, yes. Yeah, I've had one or two experiences. So I have experienced this more with prolonged surgeries, where
Yes,
when I was
prolonged
doing
surgeries.
prolonged surgery, where I was doing an ICL exchange. So in one or two patients, what happened is that we were repeatedly replacing viscoelastic, and constantly, they took a longer time to kind of get the ICL out, then putting the new one, and they were. I mean, surgery went on for 15-20 minutes. Then you start seeing these bubbles appear in the anterior
Yes.
subcapsular area, and you can actually see a proper haze, and it's very scary. because it looks like, you're having some cataract formation,
Right.
and it
Yeah.
takes some time for it to clear up post-operatively. So you're absolutely right. I think it has to do with the use of viscoelastics and the prolonged surgery that it starts inducing these kind of changes in the lens. But they all clear up. That's what I realized. I
Yeah.
mean, later on,
And also it doesn't affect the visual acuity.
it does not.
BCVA was fine, but it was for surgeon to see and getting scared. कि
Very
भाई क्या
scary on table to start seeing that change. Yes.
I think Shreya, I think we don't have any question from audience.
No, sir, there are no questions.
Then
I
we
just
can
want to
conclude.
ask, sir, just one thing I want to ask, that you said that the complications of endothelial cell loss were much more with the ICLs with holes. There was this comparison graph in between the two.
Yeah.
So what's the reason for that?
So they have not given any reason. That's basically a review article, uh, where they have considered results of all previous study. But
Okay,
to be 100% sure, you have to do a systematic review. The
okay,
baseline, everything you have to adjust and then see.
all
But
right, sir.
I don't. We have seen because the complication is very rare.
Mm,
When the complication is rare, you have to, for example, analyze for 10,000, 2,000 patients with a 20-year follow-up, which is very difficult for ICL because once the patient is okay for 3-6 months, then he's never
doesn't
going to come
come.
back to you. So
Mm-hmm.
that was.
Because I saw that there is a difference of just
Yeah.
about double uh, in the complications. So rest, we do not have any questions. I think we can conclude for the day. Thank you so much, sir. Thank you, Gaurav sir. Thank you, Tosha sir. Thank you so much,
Thank you.
Praful sir. I
Thank
think we
you.
can
Good
conclude.
night, all.
Wonderful talk, Dr.
Good night, sir. Happy
Wonderful talk.
Mahashivratri to
Thank you.
everyone.
Yeah, wish you too. Thank you so much.
Let's do some puja now.
Yes, sir. For sure.
Thank you.
Good
Thanks, sir.
night.
Night,
Good
sir.
night.